Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Welcome to another Doc Talk. Today we have two very special guests, and we're talking about something that prior I'd not heard of. You know how some folks seem like they can twist themselves into a pretzel and others can barely touch their toes, and there's a lot in between. Well, we're about to talk about ligament laxity and how it differs from flexibility and what that means, during the span of our life, and how you help treat folks with ligament laxity and what that recovery process looks like as well. So in studio, I have Dr. Eric Krohn and physical therapist Codi Grable. So thank you so much for coming in.
Thanks for having us. Yeah.
Let's start with the basics. What is ligament laxity, and how is that different from flexibility?
Yeah. Well, ligament laxity, as at least we think about it in the orthopedic world, is so you've got two stabilizers of all your joints, your static stabilizers, which are your ligaments that are ropes, and then your dynamic stabilizers, which are muscles attached to tendons. Well, those ligaments are just have an inherent kind of elasticity to them depending on your own chemicals that make them up in your own biochemistry. And there are some people who those connective tissues are just a little bit looser than other people's. So no matter how much you really stretch a ligament, you're really not supposed to be able to, you can, but you're really not supposed to be able to stretch it out like you can a muscle. Well, these people just inherently have ligaments, and honestly, a lot of their just connective tissue in general, that's just a little bit more stretchy than the rest of us. Whereas flexibility, and Codi, let me know what your thoughts are on this one, tends to be more you're inducing a looseness to, the muscles and the soft tissue structures, but It's not an inherent looseness. Thoughts on that?
Yeah, I mean, flexibility is something more that you can change, like you said, with like stretching, even sometimes different exercises. It's a modifiable factor that we have, where ligament laxity comes from more genetics and things that you're born with. So really, surgery aside, you can't change your ligament laxity.
Exactly.
Gotcha.
No matter, and even sometimes in surgery, still really can't change it just because we can tighten up ligaments. Well, the ligaments are still just inherently stretchy, so they stretch back out. Yes.
Gotcha.
It's a constant struggle.
In lay people's terms, maybe it's the difference between someone who stretches every day and works on their flexibility versus that kid in our class that was double jointed for some reason.
100%.
Okay.
Yes. They never tried to do it. They're not a gymnast, or maybe they are, but they can just, put themselves in any position, and the rest of us look at it and it almost seems unnatural with what they can do sometimes.
For sure. And that's not something that maybe the everyday person knows a ton about. We all fall on a spectrum in there. When you see a patient, how do you help them figure out where on that spectrum, where do they fall on laxity, or if they have ligament laxity versus just being really flexible?
Yeah. Well, we use the Beighton scale. I assume that's probably what you use as well. Yeah. And that's 10 points, and it's hard to kind of describe it over the radio, but essentially it's a bunch of different motions, a couple with your hands, checking for elbow hyperextension, checking for knee hyperextension, and then also with your legs straight, can you put your palms flat on the floor? It's, way more than touching your toes.
Right.
And that adds up to 9 or 10, depending on who you ask. I use the 10-point scale because the last one, the touching the ground, is I feel like a sign of flexibility, so that's 2 points, whereas I don't know about you, but I know Dr. Milligan is a 9-point person, and so we do a lot of hip stuff together, and so sometimes we have to correct each other and make sure we're describing the right way to essentially associate these patients. But you test that, and then I am a 0 out of 10, so I can show everybody what the textbook normal is supposed to be. Like your pinky isn't supposed to be able to hyperextend past your hand, but a lot of people it can, and you add that up, and most people, like you said, are on a spectrum. They're not really crossing the line to a connective tissue disorder like you may hear of Ehlers-Danlos and Marfan syndrome and those kind of things, which they can have ligament laxity, and they do have ligament laxity. But most of us are just kind of on that spectrum. I'm on the tighter end of the spectrum. I'm not sure where you are. I'm sure you've tested yourself before.
I usually use the 9-point scale. That's what we were always taught. So for mine, I'm a 5 out of 9. I've got the elbows, the knees, and then I can put my palms flat on the floor.
Perfect. So for me, you'd be a 6 out of 10. So see a higher score.
So a little bit higher. And my sister, I think, is probably way higher than that.
Oh, yeah.
She is way more mobile.
Gotcha.
Yeah.
But yeah, and so not like you have a connective tissue disorder, but it's something that, is your normal and stuff that you have to kind of address. And I don't know if you had much ligament issues or joint issues in the past, but
No, I haven't, but
that's
I
good.
am kind of aware of it. I do try and do my own homework when I can.
I would hope the physical therapist would be,
I'm maybe not the best patient, but I try.
Do
Excellent.
as she says, not as she does.
Exactly. Right.
Yep,
Yes.
unfortunately.
When someone comes to you, wondering about where they might fall on the scale, what brings them into the clinic or into your office normally? What are some things that they should be aware of that maybe you haven't thought about this before, but what are those things to look out for?
Gotcha.
I'd say a lot of times like pain, recurrent injuries. I will have, hips specifically. Patients come in and they've had ups and downs with hip pain, maybe recurrent injuries. Patients who even just have like recurrent ankle sprains or things like that where they're just not always aware of where they are, which is a component that can be hand in hand with laxity. And so they're just kind of clumsy and they get these injuries from, maybe something as simple as like, oh, I stepped off the stair and like rolled my ankle, and that happens all the time. So things like that. There's kind of a big variety that people come in for.
Just because you have, even if you test yourself at home and you're 10 out of 10, if you're doing fine, you don't need to come in and see anybody. It's really more of just if you're starting to have problems, that's something that the provider needs to address, as in, okay, this is something that may kind of become a compounding factor in trying to treat this. Like someone comes in with hip pain, and that hip pain is, due to dysplasia, which is like where the bone is a little bit deficient. Well, if they aren't ligament lax, that little bit of deficiency in their bone may actually not be a problem. But if they have that little bit of deficiency, or they're just kind of borderline, that laxity can be the thing that kind of pushes them over and is the reason why, then we need to do regular PT. If the PT is not helping, then possibly injections to kind of find out where the pain is. And sometimes we actually do bony realignment in some of these people just because, their ligaments just can't make up for that little bit of difference in their anatomy. And unfortunately, like I mentioned earlier, you can't really tighten the ligaments up. They'll just stretch out again, so you have to do other things to try and get that containment.
Which I'm excited to talk about the different paths that you do take with your patients. But before that, when it comes to diagnosis, so you did talk about either your 10-point or 9-point scale. I'm not getting in the middle of that. But you have that scale. Is that as far as you go with diagnosis, or do you often require further imaging, scanning, testing, et cetera?
I would say generally that's all I need for diagnosis. There is if you're worried about connective tissue disorders, you may be sent to a geneticist to kind of go over those things. Okay. But the hypermobile form of like Ehlers-Danlos syndrome is actually not one we can test for genetically. So it's usually we don't send people if that's all they're showing. And then in terms of other ones, there's a lot of other findings that you'd have with their ligament laxity. But if it's just ligament laxity, usually that's enough of the diagnosis. And we generally don't push the line and say, oh, you actually have a connective tissue disorder, just because we can't really figure out the 9 or 10 out of 10 scales versus the mild hypermobiles. I mean, we can sometimes, but there's not like a good test for it.
Gotcha.
It kind of depends in physical therapy on what they're coming in for. If someone just wants to see if they're hypomobile, then we kind of just draw the line at the Beighton scale.
Yeah.
But if we've got other things going on, they've got pain, or they've got other issues going on, we will use things like strength testing, range of motion testing, which range of motion can look at ligament laxity, kind of, if a person can, again, bend into that pretzel, but it also looks at muscle length, if we've got some lacking things there. Yeah. And then there's other what we call like special tests that we can do to see if the hypermobility or the laxity is causing the pain, or maybe there's something else going on there. So we've got a few things in our toolbox, but again, that depends on why the patient is actually coming in.
For sure. And both of you had touched on a couple of reasons maybe a patient comes in, whether it be hip pain or they notice that they have hypermobility, like some of these things that you can notice. But we've also heard of other things like scoliosis or rotational issues, bunions, flat feet. How do all of these connect in the grand scheme of things for the patient?
You can definitely have people with 10 out of 10 or 9 out of 10 scale. I'm going to have to do that every time now. And have none of these things. And then you can have people come in who have scoliosis. They have flat foot. They have, adolescent bunions. The rotational malalignment issues. it's hard to say, do people just like to sit in certain positions from their laxity and that's what induces the twist? It's hard to say. It's definitely not everyone that has ligament laxity has these issues, but if I start to see these issues or a constellation of them, like someone comes in for specifically like adolescent bunions and scoliosis, I'm going to test their ligaments out because I'm fairly certain they're going to be found to be hypermobile.
Right.
Yeah, I don't know if I really have anything to add for that.
Add to that, yeah, that's definitely in terms of the deformity and everything more on the orthopedic side, and unfortunately when they're that bad, there's not a lot of PT options that we can have once it induces deformity. But just because you have laxity doesn't mean you'll have true bony deformity. It's just something that can be associated with it.
Okay. And both of you have also touched on hip pain. It seems like something that you're both focusing in on. Yeah. Could you elaborate on that?
Yeah, I think a part of it is because we're both part of the Hip Preservation Institute now.
That's important.
Which has been really fun. But if you have ligament laxity, you're more prone to some of these things. If the ball and socket joint is not as stable, you've got some play in that joint, or you have some damage caused by some of these deformities, you can have pain, and that's really important to treat. No matter where you are in life, especially if you're younger, come see me, come see Dr. Krohn. We want to make sure that we're addressing, and if it's something that you're on the lower end of the laxity spectrum, and physical therapy can help you by improving joint stability through muscle strength, or other deficits like length imbalances, even just sometimes how people move can impact their pain. We can help you with that in physical therapy. If you are on the higher end of that spectrum, there's a lot of times where we try physical therapy. Patients are really good about their exercises, really good about, all of the recommendations that we give. And they're like, gosh, I'm just still having pain. I'm still having functional deficits. I'm not able to do what I love. Then, we defer to Dr. Milligan and Dr. Krohn.
Yeah, and I'll also add Dr. Metzler in there, part of the team as well, just because when we all really start with therapy for honestly most issues that you come in for, but hip pain, there's so many different reasons why you could have it, even if you have some laxity, even if you have some bony issues. And, you'll even find things that people will be treating like the big muscles on the outside of the hip because there's some issues with the tendons. Yeah. And it turns out they actually have a little bit of dysplasia and a little bit of laxity, and those tendons are irritated because they're working overtime to just kind of keep that hip stable. And so therapy to work on, reducing the micro instability that happens with these people is a lot of times all we need. Sometimes that doesn't work though. And so then if we don't have a clear line that the pain is coming from maybe the joint or the tissue surrounding the joint, then one of our sports med docs will do an ultrasound evaluation, look for areas of inflammation, do some motions that cause pain, do some injections, and then do the motions again to see how they respond to that. And that's where we can kind of get some more information of, okay, this pain is really coming from the hip joint. Maybe their MRI was negative. They have a little bit of dysplasia. They have some issues with ligament laxity, and the tendon on the outside looks a little bit irritated. The injections helped a little bit. Okay, this is starting to quack like a duck. Like this is probably the cup is not able to contain the ball and socket well enough. Sure. Or kind of conversely, your extra mobility could lead to where two of the bony pieces are kind of pinching each other, and that can pinch soft tissue structures and cause damage that way. And if you don't address this early enough, and whether that's with therapy, that, like I said, not everyone needs surgery. Right. If therapy nips it, that's fine, but it might just be a lifelong thing. But if it doesn't help, or the pain keeps coming back and you keep getting these recurrent injuries, it does lead to joint breakdown. And you will see people, Dr. Milligan, since he does the adult joint replacements, will see them all the time. Late 30s, 40s, young people, healthy people who need joint replacements because they've had hip pain their whole life, and everyone's just kind of been like, well, I guess you have hip pain. I don't know if there's a problem. And these kind of nuanced details are things that have just kind of started to come about more in the last 20, 25 years.
Okay. And our muscles and our joints, it's all a connected system. And, to me going about my everyday, I'm not understanding how, some muscles are overcompensating for others, or how maybe the pain I'm feeling is a joint or ligament issue. So when someone comes into your office, say for hip pain, and they just know that they have hip pain, right? Yeah. How do you take those steps to help them understand, this is the process we're going to go through to help make you feel better, to eliminate, any other outlying issues? What kind of steps do you take to help the everyday person understand what's going on with their body?
If you first meet me, I say go to therapy. So I'll pass that off to see what Codi has to do with her people when they first come to see you.
Yeah, a lot of education. I get through my initial evaluation, and then usually I will sit down with the patient and just say, hey, these are the things that I'm finding. These are the things that's fixable. And we want to address this first, because if we can avoid surgery and avoid that higher risk thing by doing low risk, therapy is very low risk and, to be honest, less expensive. If we can do this and get you happy and healthy and doing the things that you love without pain and without limitations, then let's start here. Now, I say if there's red flags or things on my exam that I say, hey, I'm not really sure that this is going to be where you're at, we can always give therapy a shot. Again, it's low risk. There's no harm in giving therapy 4 to 6 weeks to work. And if it works, amazing, great. We can keep going. We can get you where you want to be. Or if not, then we do send you over to ortho or, the other parts of the care team, because we want patients to be back on their feet and doing what they want as soon as possible. We're not going to keep you in therapy or doing things, or just say, hey, sorry, you have hip pain, kind of deal with it. You know. We want to push those patients through that continuum of care to the best of our abilities. But we also don't want to skip steps and have unnecessary procedures or unnecessary surgeries, because that's
if we just go off of imaging, sometimes there are X-rays or MRIs or CT scans that might make me think, oh, I'm going to have to do surgery on this person, but they've never tried therapy, and then they go to therapy, and if they get better, well, I don't really care what the images show. Like, we treat people, not images.
Right.
But there will be times where, our therapists have seen people with these issues get better, and there are plenty of times where they'll reach out and say they're not getting better, and so we don't even do the full round of therapy. We're like, okay, let's come on back in, let's talk about other options. This, of course, if you have a bad labral tear or something like that, we might not start with therapy, depending on your history. But the vast majority of the time, if you're not advancing and they think they're doing the right things for you and they think they're getting the right amount of effort out of it, eventually you just stop, beating your head against the wall, and they just reach out and say, can you bring them in for injections, and then possibly talk about surgery. And usually we've met them before. We all meet every month to go over some of these patients at least and talk about our post-ops and everything. So a lot of these patients we've started talking about before they've even, gone through a full round of therapy or anything like that.
It's good to know that you guys talk about it.
Yes, we do.
And it sounds like a highly collaborative process between physical therapy and then maybe that next step to surgery. Can you talk about, what is a diagnostic injection? It is a diagnostic.
Yes. Okay. So it can be diagnostic and therapeutic. So a lot of the people we're talking about right now tend to be on the younger side. Adolescents, young adults, people who you don't just want to be treating their pain with injections. Steroids have risks, and inside of joints they can really lead to joint breakdown. And same thing can local anesthetic. So we don't just want to do that like we would a 65-year-old person with end-stage arthritis who we're just trying to, make them feel better until they eventually say, I want a joint replacement. So in this case, what we do is it's really just local anesthetic. Now, there may be some times where Dr. Metzler, one of our other sports partners, will recommend they do some steroid with the local anesthetic.
Okay.
But generally when you're in this pathway for the Hip Institute, when we're really worried that you're someone who's not just going to do better with just therapy, to say that, we'll do an injection and then everything will be better, well, we've kind of already said that we can't optimize your bony anatomy and everything with just making things stronger. So by knocking down the inflammation to make you feel better, it's really just putting a Band-Aid on a problem. The diagnostic injection, though, can help us figure out where exactly is your pain coming from. If we put it inside the hip joint and you get better, then it only lasts for 15 to 30 minutes, but that's okay. You got better. We know that that's your pain generator. And if he puts you through a whole bunch of motions, a certain motion hurts, you inject the tendon around that area, and then that motion doesn't hurt anymore. Maybe that was the problem.
Okay.
And so that's one more way we can just kind of confirm. And most of the times when we're sending people for those injections, we're pretty sure we know where the problem's coming from. The PTs have worked on them. We've seen them. We know what their anatomy looks like. But it gives us that one last, yes, that's where the pain is coming from if we don't have, an obvious tear. So then we know, okay, you are the kind of person whose best chance is surgery at this point.
Okay.
And it helps to prevent, at least from my standpoint, it helps to prevent procedures that maybe aren't going to be beneficial for that patient.
Yes.
I think we've maybe all heard of a story of like, oh, my hip hurt and I had this surgery and it didn't work. And then I ended up having to have like a back surgery or something like that, because there are very much other structures in the body that can masquerade as hip pain or masquerade as pain somewhere else. And really it's coming from up or down the chain is what we say. And so if we do a diagnostic injection in someone's hip or ligament or a tendon and it's not working, okay, do we need to look somewhere else? Do you have some nerve issues or something coming down from the back that is masquerading as a hip pain? And usually we catch that before it happens. But sometimes there's the one-offs that happen that we're like, okay, this is characteristic hip labral tear, and we do an injection in the joint and the patient doesn't get better, and it's like, okay, well, now what? So then we can start looking up and down the chain, so we're not doing an unnecessary labral repair on a patient who really needs a back surgery or therapy or something on their back.
This is an anecdote from when I was back in residency, but I remember a girl coming into the children's hospital that I was at saying she'd been having hip pain for so long, and finally the providers were like, all right, well, we're just going to stick a scope in there and see what is going on. And the mother and patient were both like, I really don't want to do exploratory surgery. So they came and saw my provider and myself, and it actually turned out, and from their story, that they have a pain-producing tumor up in their spine that activated the L3 nerve root that comes across there, and that's where they were having pain. And if we had, in that case, we figured it out before needed to do injections, but if that patient had come through our pathway and we were at that point where we were saying, yeah, let's stick a scope in there, the diagnostic injection would be that one more check to just say, yes, that's where the pain is coming from. In this patient, it wouldn't have gotten better. And if we still stuck a scope in there, well, then we are definitely, had blinders on if that's the case.
Absolutely.
But that should be enough to get us a step back to say, is the pain coming from somewhere else? I mean, we even have a general surgeon in our hip institute, Brianna Conant, who looks if there are people who have hernia issues and they're having hip pain. There are several different reasons why it could be hurting.
Makes sense. Our bodies are very complicated, which is an understatement of the century. Once we do get to the surgery part, maybe a patient, you've both determined, through your collaboration or talking to the patient, what kind of surgeries does this look like? What happens when you have ligament laxity?
So it does kind of depend on what other things are going on and what your true mechanical problem is. Like dysplasia and laxity, think of it like there's just not enough containing the hip and it just wants to kind of come out of socket. And so you have to do surgery to kind of contain that a little better. Whereas if it's more from impingement, then that could be also an instability issue, but more that there's two bony prominences that are running into each other. And so surgery, if you're on the dysplasia side, is most of the time talking about redirecting the cup to better contain the hip, because bone is, even though there are some differences technically in connective tissue disorders, for most ligament laxity people, their bone is going to be exactly the same as anyone else's. And so being able to use that to contain the hip should be effective, whereas you can't really tighten up the ligaments. In terms of impingement, sometimes it's actually reducing some parts of the bone, usually not the parts that are actually inducing stability, but ones that are just outside of that area that can pinch together. And sometimes it's actually changing the rotation of the bone in the femur so that your arc of motion, your range of motion is actually different, so that you're less likely to get into that position to cause those bony pieces to come together.
Okay. And for those unfamiliar, impingement is?
So impingement is where those two bony prominences anywhere really are coming together and they're pinching soft tissues in between. Okay. And you'll hear about FAI in the hip world in orthopedics, or just impingement. But that's kind of another common thing that'll happen that could lead to that hip joint breakdown.
And a lot of people, when we're talking about surgery, they're really scared when it comes to recovery. That's the part that might freak people out. And I have a feeling, Codi, that this goes back to you. Mm-hmm. What does this recovery process look like? And how does the communication between, surgery, physical therapy, and the patient, what does that look like?
Yeah, it's really dependent on what the surgery is. And recovery, for me, can actually start before surgery. I will oftentimes see patients before surgery for what we call prehab. And that's just to help kind of optimize how a person is moving and doing before surgery. Strength is a big one. If we can get you stronger and moving better before surgery, even if there's a little bit of pain, you're going to do a little bit better after surgery. Now, after surgery, usually depending on the surgery, I'll see someone as soon as 2 days after surgery. Sometimes if it's more complicated and we really want some of those structures to have some time to settle and heal, it'll be a few weeks after. But I bring patients in the first visit. I do a lot of talking. I really like to try and help calm the fears. I kind of talk them through, hey, this is the protocol, and a protocol is something that the surgeon will send us and say, hey, these are things I'm okay with you doing as far as range of motion, different activities. These are things that are okay and safe to do at this point post-operatively, and then that kind of goes through the continuum. So I'll take patients through that, and I'll just say, hey, this is what it's going to look like. This is where we're going to be starting day 1, 2, 4, 6 weeks down the road. This is what you can expect. And then we obviously talk about things like pain control, things like that. I work really close with the surgeons on helping patients with pain control. Hey, so-and-so is in here. They're not taking their medication, or they're not tolerating their medication. Is there something else we can do because they're just not able to tolerate what we need to do after therapy? So there's a lot of things we can do to make rehab and post-operative care more comfortable and really less scary for patients. And just know that we're always talking with your surgeon. They're always kind of reading our notes and communication with us, making sure that everything is going the way that it should be. And we're all pretty well versed in these. We're not going to do anything with or to a patient that's going to chance risking a surgery. I think Dr. Krohn knows that we in therapy tend to be on the more conservative side because we don't want to risk a repair that they've just spent a ton of time doing.
I had one of the other therapists reach out to me yesterday and just ask about a patient if we can increase the weight bearing because we did something a little bit different. We actually had to change the rotation of his tibia, and that just comes through as something that we don't usually do for hip stuff. And so they were like, "Hey, what do you think about this?" And it's just nice to see that they're always communicating with us. They see the patients more often in those first few months, really, than we do. So their communication with us really helps us kind of guide any additional changes we need to make through therapy. But the general therapy, depending on what you end up having, the general recovery is probably about 6 to 8 weeks of limited weight bearing, if not no weight bearing. Okay. And then after that is where you really start to increase your weight bearing, getting back to regular activities. And that's when the therapist can really start to strengthen things up. The bone is healed. Now we're trying to get you back to where you were before this all started, or hopefully better than before you all started.
Right, and those 6 to 8 weeks being an investment in the rest of your life, right?
Yes.
The rest of your time with your ligaments and bones and tendons and all that.
It's a really good way to put that,
yes,
actually.
Yeah,
it's a very good way to put
definitely. And because the detriment to getting a joint replacement in your 30s or 40s is extraordinary.
Yeah.
We might have different technology in a few years, but I don't think we're going to figure out all of the issue. You can't ever make something as good as it was before with surgery. You can just kind of make it a little better. And when you get joints done very young, there's a good chance they'll wear out before you are done needing them, per se. And revisions and all that stuff, there's diminishing returns of benefit every time you have to do more surgery. I wish it wasn't the case. I wish we were better at that. But the less surgery we have to do to you, the better it ends up being.
It makes sense. But we are all human. We know that physical therapy is very important, but as someone who has maybe not been an A-plus patient in the past either, it happens, okay? How do you keep people motivated through what is probably, a trying time for them? They're not moving the way that they used to, and they know that physical therapy will get them there, but that's 6 to 8 weeks of, maybe not putting weight on your leg or your hip. How do you keep people motivated through that process?
That's a tough one. Some patients do it on their own. They're like, you know what, I don't want to do this again. This was terrible. Like, I want to feel good. And so they do it themselves. Other patients need a little more encouragement. I do, again, a lot of education, just saying, hey, it's a short-term sacrifice for a long-term gain. If you follow these recommendations to the best of your abilities, you're going to feel so much better for so much longer. And the risk of you re-injuring or delaying your recovery is a lot less. And then I do focus on long-term goals. Like, hey man, you want to get back to running marathons or something as simple as like hunting, hiking, those sorts of things. You want to get back to this. Like, this is the road to recovery. If I had a magic wand and I could, boop all my patients on the head and say, here, you're fixed. I totally would. But I might still have a job, but I'd
be a little bit easier, maybe.
Be a little bit easier, but there's just no magic potion to get patients you know, that way quickly. I mean, it's got to be, like you said, an investment, and you know, some of it does fall back on the patient just being understanding of that, and having their own intrinsic motivation of like, this is terrible now, but it's gonna pay off in the end. And the patients who can kind of internalize that do tend to do a little bit better than the ones who just kind of say, you know what, I don't really want to do this work, and that's always a tough thing to do. Sometimes I call in the surgeon and say, hey, I need you to read the right act.
Yep. But that's also an assessment, you know, we make as a team kind of before then. If this is someone who you've been sending to therapy and they haven't really given the, you know, push that is needed to really say that therapy hasn't worked, is that someone that we really should be advancing to surgery? Like, there's a couple reasons there. First off, they might not even need it, and we've never really done the treatment that's needed. And then the second reason is, well, just because we can realign the bone, if we don't make all of the muscles strong afterwards, you are still probably going to have a pretty tough time with it. So that's someone who you don't want to, you know, proceed with surgery. But that's not a common thing. Like, especially in the age group we're talking about, we have a lot of very driven people who have had to stop sports because of their hip pain. You know, they were quite the athlete before, and so now that we're saying, hey, well, hopefully we can get you back to that point, I think that's a big carrot on the end of a stick that, you know, people kind of sprint towards. There are going to be some who, you know, aren't in that boat, but it does seem to be a lot of the people we've ended up doing this on were very motivated, have been having pain for years, and just want to get back to some semblance of normalcy.
Yeah. I do think that's a common misconception sometimes that I deal with in therapy a lot, is patients will come in and they'll be like, well, I don't know why I'm doing therapy anyways. Like, why can't I just have surgery? And I'm like, well, you know, but surgery's not the begin-all. Like, surgery is a piece of the puzzle for most things, especially in the orthopedic world. It's a piece of the puzzle. And if you just want to have the surgery and then go home and sit on the couch for 6 months, like, not only are you not going to get better from problem A, you're probably going to result in B, C, and D other problems, because, you know, surgery affects your whole body, and it affects how the entire limb moves. And that's a thing that patients, I really want them to understand, of like, we have to put that work in, because now we've, to the best of our ability, corrected this problem, but now we need to optimize how you're moving globally to not only protect that repair, but protect the rest of your body during the things that you want to do. And that's, you know, surgery.
Yeah. If you think the therapy is too hard before the surgery, the therapy is certainly going to be too hard after the surgery.
That's fair.
Yeah,
That's
not. It does not make the therapy easier in the end. It makes it quite a bit harder.
Yep.
We are all just complicated puzzles, and I appreciate, and I'm sure your patients appreciate, both of you and your team, you know, shedding some light on the mystery that can be our bodies sometimes. Anything else that you would like people to know about ligament laxity, or just awareness before we wrap up?
You may be ligament lax. That doesn't mean you're abnormal. I like to, and I've said it before, we're all on a spectrum of what is normal. The textbook normal that you read about in school is a very rigid definition. And so you might be 9 out of 10, 10 out of 10, and totally normal. And you may be 10 out of 10 and then start to sprain your ankle, and then you have issues with ankle instability that wouldn't have happened with a person that's 0 out of 10, and then we have to address that. But just because you have the laxity doesn't mean you are broken and your just body is going to have a lot of issues. But if you do have it, and you have pain, there are things we can do about it, because it's a very addressable problem. Unfortunately, most of the time it's therapy. And I do feel bad. People come to see me in the surgeon's office, and they're like, I've done therapy, I have ligament laxity, what do I do? Probably some more therapy.
More therapy.
We're usually pretty fun, though.
Yes, yes, exactly.
You guys are fun.
Yeah.
Come hang out with us. We'll have some fun. We'll do some cool stuff to get you feeling better.
It is hard. It is hard to do
it's
therapy.
Work.
Yeah, but it does work. And we're not just sending you there so we can check some box for the insurance company to then do your surgery. If there was someone who came through who needed surgery and we knew therapy was just a waste of time, we go and do surgery. You know, we don't try and have you do therapy with a broken femur, right? But it's just one of those things that I always feel a little bit bad telling patients who have already been through a lot of therapy that, well, you're just going to be doing more.
Yep.
That's
Yeah.
Put a period on that, because
Exactly.
I like that. That's great.
You're just going to be doing more.
Well, it's good to know that it's addressable, and it's fantastic to hear that there's such a collaborative team over at Monument who are constantly looking for ways to improve, you know, the lifestyle and the life of your patients, and you seem to really care a lot. So thank you so much for both coming in. shedding some light on something I never heard of prior to today. So, and hopefully the same for some others as well. So Dr. Krohn, Codi, thank you so much for coming in, and hope to see you again.
So nice to meet you.
Thanks for having us.
Yep.